Okay, welcome. I think the time is okay for us. So, can you hear me?
Yes, very good.
Okay, let's start firstly. And I think some customer is in the studio. So, Nick, please help allow them in. Thanks. Okay, ladies and gentlemen, good morning, good afternoon, and some friends, good evening from different countries. I'm Bob, TS manager. Today, I'm on behalf of ReMed to welcome you to attend our online webinar. In the first half of 2020, ReMed had held several webinars successfully, with audience covering dozens of countries and regions, more than 100 doctors and distributors. At the meeting, we explored the multiple emerging technologies and tools for imaging diagnosis in cardiovascular medicine. The Flash NU CFFR system is well received in the clinic application of the hospitals because of its high accuracy, avoidance of adenosine injection, faster, economical, convenient, and accurate help for doctors to diagnose coronary artery stenosis. Today, we are fortunate enough to invite Professor Liu Jian, Director of Department of Cardiovascular Medicine of Peking University People's Hospital. The main research interests of Professor Liu are as below: diagnosis and the treatment of coronary heart disease, intracoronary imaging and functional examination, coronary interventional, coronary heart disease examination, diagnosis and treatment of acute myocardial infarction, interventional treatment of resistant hypertension. In addition, Professor Liu is also an expert member of American College of Cardiology, an expert member of European Society of Cardiology, and an expert member of American Society of Angiography and Interventional Therapy. In addition to his work, Professor Liu's team is also actively committed to public welfare undertakings and carries out social science popularization of cardiovascular disease. Next, Professor Liu will share the research in the field of FFR as well as the CFFR cases in practical application with us. During the presentation, if you have any question or doubt, please kindly drop the question into the studio. Then we will organize to answer the questions. Okay, now let's welcome Professor Liu. Professor Liu, please welcome.
Ladies and gentlemen, good morning, good afternoon, good evening for all friends from different countries. I'm Dr. Jian Liu, Professor of Medicine, Department of Cardiology in Peking University People's Hospital. Today, I'm very honored to be here to share FFR usage on functional assessment of coronary artery disease. Next, please. Next slide, please. So today we include 5 parts in my presentation to be shared. Next, please. And the first part is traditional diagnostic method of coronary heart disease. As we all know, normally we can evaluate the degree of stenosis according to visual inspection with the help of CAG, IVUS, OCT, CTA. Through CAG is the golden standard of diagnosis of coronary artery disease, where we cannot assess the ischemia situation according to the visual inspection. So some new technology was developed. FFR, based on the pressure guidewire, was coming. It can help physicians to know whether stenosis can be caused myocardial ischemia or not, because it helps to detect proximal pressure and hyperemic situation as distal end. Some other new functional methods, such as CFR, IMR, it would help physician to know more information about stenosis. For example, even we get normal FFR value, there might be chest pain in patient if microcirculatory is not so good, or if microcirculatory is good, even there is severely stenosis, the FFR might be normal. Next slide, please. Next slide, please. I conduct study to show, back. I conduct a study show that there were two types of stenosis lesion in patients that could induce myocardial ischemia and could not induce myocardial ischemia. In contrast, stenosis that can induce myocardial ischemia leads to more death and myocardial infarction. So it is critical to identify these two types of stenosis. The functional evaluation provided by FFR is precisely an indicator to identify those two types of stenosis. Next slide, please. Next slide, please. The FAME study, which published in the Journal of American College of Cardiology, showed that the FFR-guided PCI reduced mortality and myocardial infarction by 34% at 2 years, reduced the amount of contrast media used and lowered the general cost. The 5-year follow-up results of FAME2 study show that the MACE happened to FFR-guided PCI group was significantly lower than the medical treatment group. The study results show that the patient with the moderate stenosis, 50 to 70% stenosis, 1/3 of them will be ignored by the angiogram alone. Patient with severe stenosis, more than 70% stenosis, 20 of them will be overtreated by angiography alone. Next slide, please. Next slide, please. Yes. With the past research, we know some conclusion as below. Imaging morphology method do not identify lesion that cause myocardial ischemia in patients. Imaging morphology method may overestimate or underestimate of severity of lesions, resulting in untreated or overtreated lesions that require treatment. Imaging morphology method does not consider the situation of cholesterol circulation or myocardial abnormality. The visual inspection method usually fails to give the physician the exact information of the lesion. Next slide, please. Next slide, please. Because the limitation of visual inspection based on imaging morphology method, the FFR was brought to give the functional assessment of lesion severity. In 1993, Nico H.D. Fitlis, MD, PhD, proposed fractional flow reserve, FFR, a new indicator of coronary blood flow driven by the pressure measurement. After long-term basic and clinical research, FFR has become an accepted indicator for functional evaluation of coronary stenosis. In the presence of a stenostic lesion in a coronary artery, the ratio of maximum blood flow that can be obtained in myocardial region supplied by the vessel to the maximum blood flow that can be obtained theoretically under normal condition in the some region. At a maximal hyporemia state, the RS hyperemic myocardial resistance in the presence of the stenosis is approximately equal to Rm, normal hyperemic myocardial resistance, so that definition of FFR can be converted into the ratio of mean intracoronary pressure PD at the distal end of the stenosis to the mean intracoronary pressure PA at the maximum hyperemic state of the myocardium. Next slide, please. Next slide, please. According to the number of studies, FFR is the golden standard of functional assessment. The trial FAME1 elicited some conclusions as below. Hemodynamic relate to stenosis can be identified accurately by FFR-based assessment. 2 years composite risk of death or myocardial infarction met significantly lower with the FFR guide PCI strategy. The cost of treatment was reduced. The dosage of contrast medium was reduced. Outcome and the quality of life was improved. Another trial, FAME2 study, has proved that the benefit of FFR guide PCI. Here are some conclusions from the trial FAME2. In patients with the stable coronary artery disease and the functional significant stenosis, FFR guide PCI decreased the need for urgent revascularization in patients without ischemia. The outcome appeared to be favorable with the best available medical therapy alone. FFR guide improved long-term outcome and is economically attractive compared with the medical therapy alone in the patient with stable coronary artery disease. Next slide, please. Next slide, please. It is fact that FFR guide PCI can reduce MACE event in patients, and the FFR has been added into the guideline. Next slide, please. Into the guidelines on myocardial revascularization in 2018 EIC EACTS. In Class 1A recommendation that when the evidence of ischemia is not available, FFR or RFR are recommended to assess the hemodynamic relevance of intermediate grade stenosis. In the Class 2AB recommendation that the FFR guided PCI should be considered in patients with the multivessel disease undergoing PCI. Next slide, please. For the traditional FFR measurement, pressure wire is needed to detect the pressure of distal end, and adenosine can be helped to make the blood vessel to the maximum hyperemia state. The operation is whole invasive operation. Next slide, please. At this stage, the patient with moderate stenosis in Europe, United States, and other developed countries must undergo FFR diagnosis before planting a cardiac stent. For a global perspective, application of FFR is not ideal due to the following possible reasons. The first is high cost of imported pressure guide wire. The second, invasion of the distal end of the diseased blood vessel may be induced plaque rupture or damage the blood vessel. The third, intolerance to some patient or side effect from the vasodilator adenosine or ATP. Firstly, longer operation time. Next slide, please. Next slide, please. Of course, there are some limitations of pressure guide wire. The operation of the pressure guide wire is complicated. Zeroing, collaboration, equalization, hyperemia, verification after pullback are required. When the blood vessel is not fully expanded, it needs to increase the drug dosage and the remeasurement. At the same time, the operation process is an invasive relative operation, and there are problems of wedging or pressure wire drifting. The pressure guide wire need to be combined with the vasodilator drugs, and some patients has drug control indication or intolerance. The overall operation time of the pressure guide wire is long, which increases the risk of surgery. Next slide, please. Fortunately, now we have the new technology, non-invasive FFR-based CAG, the flash angio CA FFR system. Next slide, please. Coronary angiography driven FFR, CA FFR, released measurement of pressure different and FFR by the computational fluid dynamics based on coronary angiography. Next slide, please. Next slide, please. The principle of CAFFR is as below. 3D revascularization is based on 2 coronary angiogram imaging. Capture real-time aorta pressure via flash pressure transducer. TIMI-free count method to obtain the blood flow velocity. Calculate pressure dropped and the CFR via optimized CFD algorithm. Next slide, please. Next slide, please. After we get to angiographic projection, aorta pressure obtained by the flash wire, resting flood velocity obtained by TIMI-free count, we can get CAFFR value according to the optimized CFD in flash angio system. Next slide, please. Here are some features of our CAFFR system. It is non-invasive and non-adenosine needed, which would reduce risk of physician and the discomfort caused patient. With the innovative algorithm and the efficient workflow, we can get good accuracy, 95.7% accuracy, 95.7%, which verified by pressure wire, and the whole procedure is 3 to 5 minutes. And the IMR and IFR can be developed based on our special flash wire transducer also. Next slide. Next slide. Here is our special pressure transducer, flash pressure. It can acquire the aorta pressure at the time of angiogram. Some new feature would be applied on the transducer, such as wireless transmission of pressure data, one-button automatic exhausting and zeroing collaboration function, high pressure protection to prevent reflex. Next slide, please. Okay, next we would introduce the CFFR measurement procedure. Two orthogonal imaging is selected for the three-dimension mass reconstruction. The two angiogram should be within an angle equal or greater than 30 degrees. Next slide, please. Next slide, please. The resting fluid velocity can be calculated by Timmy free count method and the 3D vessel length.
Professor Liu?
Next slide.
Hello?
Yes, yes.
Okay.
What's wrong?
Just now, we couldn't hear anything. Now it's okay.
Okay. So the voice is good now? The voice is good?
Yeah.
Okay.
Yes. Now it's okay.
Okay.
Exactly.
And the next slide, please. Can you hear me? Next slide, please. Can you hear me? Next slide, please.
Yeah.
The real-time aorta pressure PA is recorded by the special flash pressure transducer, and it can be converted into hyperemic aorta pressure PA using a simple formula in the flash angio software. Next slide, please. The pressure gradient across the region is then computed using a proprietary simplified CFD solver. I think too much, okay? And this is, yes. After the finish the examination, we can get diagnostic report and the measurement results. In the report, we can see the key information, lesion position, PD, velocity, CFFR of the case. The report also can be exported to removable disk. Next slide, please. Next slide. The next part is clinical application of CAFFR. Next slide, please. Here is the application scenario. The flash pressure can be connected to the Minford and IBP cable from the analyzer. The pressure wave signal can be captured by the pressure transducer and transmitted to the workstation for the CFFR calculation used. Next slide, please. Next slide, please. The CFFR system can be used to assess hemodynamic relevant stenosis in patients with multivessel disease. Next slide, please. CFR can be measured functional severity of serial lesions and can be used to predict the functional outcome of the post-PCI. Next slide, please. Here we can see outcome if patient is conduct in the proximal region. It seems as PCI in the proximal region cannot solve the ischemia problem. Next slide. Here we can see the outcome if PCI is conduct at the distal region. Next slide. If PCI can be conducted for both regions, the ischemia would disappear. Next slide, please. Next slide, please. CFR can be also give assessment of the hemodynamic relevant range in diffuse region. Next slide, please.
Как эту хуйню свернуть? Алло.
The CFFR value can be checked at a different position of the vessel, and we can know key FFR gradient, which is important for physician know the position for PCI. Next slide. Next slide. Here is the predicting of the outcome of post-PCI. Next slide, please. Next slide, please. Next slide, please. Okay, one back. CFR. Okay, back. Okay. So CFFR can help guide PCI strategy and estimate set branch in bifurcation regions. Here we can see the mean vessel CFFR is 0.60. Next slide, please. The set branch CFFR is 0.82. So we can know that criminal branch in bifurcation regions. Okay. Next part is the evidence of CFR flash FFR study. Next slide, please. Next slide, please. The flash FFR study was a prospective, multi-center, single-arm study conducted at 6 centers in China. The eligible patient had native coronary artery target lesion with visually estimate diameter stenosis of 30 to 90% and the diagnosis of stable or unstable angina pectoris. Next slide, please. The result of flash FFR study has been published on ESC. Next slide, please. Next slide, please. The study aimed to compare diagnostic occurrence of CFFR and invasive FFR. Eligible patient had native coronary artery target lesion with a visible estimated diameter stenosis of 30 to 90%. CFFR was measured online in real time and compared blind to conventional invasive FFR by an independent core laboratory. About the study, the primary endpoint was the diagnostic accuracy of CFFR using wire-based FFR as the reference standard, which clinical significance cutoff value was 0.80. The target goal of the diagnostic accuracy was 84%. Next slide, please. Pair CFR and the invasive FFR were available for analysis in 328 vessels with the lesion in 328 patients. The predominant patient presentation was unstable angina pectoris. The left attending descending artery system 59 0.5% was the most common vessel, assessed vessel, followed by RCA 26.5%, RCX 11%. For the lesion itself, the bifurcation lesion 26.5% and the calcified lesion 18%. The overall diagnostic characteristic for all the integrate vessel are shown in the slides. The diagnostic accuracy was 95.7%, sensitivity was 90.4%, specificity was 98.6%, positive predict value PPV was 97.2%, negative predictive value NPV was 95%. In 118 vessels was FFR between 0.75 to 0.85. The CFFR diagnostic accuracy was 89.9%. DA, SN, SP, PPV, and NPV for the sensitivity analysis are shown as above. As we know, the critical zone is the most important, which is common judged during the clinical application. Next slide. Next slide, please. Next slide, please. The total operation time of CAFFR was 4.54 plus 1.48 minutes, which is much faster now. CFFR was highly correlated to FFR, R equal to 0.89. The blind outcome plots for the pairwise comparison show as there, and the receiver operating curve from online CFFR shows AUC 0.979. Next slide, please. Here are the conclusions of FLASH FFR study. Use wire-based FFR, Use wire-based FFR as the reference. CFFR has high accuracy, sensitivity, and specificity. CFFR could eliminate the need of the pressure wire, technical error, and potentially increase the adoption of physiology assessment of coronary artery stenosis severity. Next slide, please. We can know the target performance of CFFR system in the FLASH FFR study. Now, new study, FLASH 2 study, is underway. FLASH 2 is a prospective, multi-center, blinded, randomized, non-inferior clinical trial of coronary angiography functional flow reserve CFR versus fractional flow reserve FFR to guide percutaneous coronary intervention. The purpose is to investigate if CFR diagnostic strategy will lead to non-inferior clinical outcome after 1 year compared to a standard FFR guide revascularization strategy. And the primary outcome measured a composite endpoint, all-cause mortality, any myocardial infarction, and any unplanned revascularization. At the same time, the group of international advisors was invited to make this more scientific and ridiculous, valuable proposals. They are offered by Professor Jiver, Gray, and William Ferry, etc. We trust the trial would be a great success. Next slide, please. Okay, the last part, we have some case to show you. Next slide. This is a 65 years old gentleman with the unstable angina pectoris. According to the CAG examination, there is a LD bifurcation lesion. The visual stenosis is about 70%. Let's have a look at the angiogram. You can see the angiogram. Okay, then next slide. After the examination, the result of the CFR was positive, 0.82, which was verified by the pressure gauge wire. The next case is 67 years old gentleman with a coronary artery disease and type 2 diabetes mellitus. The visual stenosis of the middle part of LAD is about 60%. Let's have a look at the angiogram. Then, after the examination, the CFR was positive, 0.776, which was verified by the pressure gauge wire with FFR value 0.77. So let's come to the conclusion. The induction of CU and the FFR and the CFR for the future perspective, we sincerely hope that CFFR will be widely used for diagnosis and assessment in cardiac catheterization laboratory. Functional assessment is available for the intermediate gradient stenosis, multivascular disease, cerebral lesions, diffuse lesions, bifurcation lesions, and post-PCI evaluation. CFFR significantly reduced the cost without increasing operation time and risk. Thank you for your attention. Thank you very much.